Hello, final night. Thank you very much for coming out. I noted as I walked up here that it's a lot sunnier or later than it was when we started, and that's a nice thing. So this evening we're going to hear from Catherine Bowser. She's a vascular surgeon employed by Christiana Vascular Specialists. She grew up in Chester County, Pennsylvania, and attended Drexel University in Philadelphia for both undergraduate and medical school education, where she graduated summa cum laude. She completed a 5-year general surgery residency here at Christiana Care and then a 2-year vascular surgery fellowship at the University of Colorado in Denver. And while having been in Colorado, you still came back to the East Coast, and we thank you for that. She's an avid runner, winning the New Jersey Marathon and running the Boston Marathon in under 3 hours, and that's impressive. She's a mother to an inquisitive, loquacious 8-year-old artist, scientist, and gamer, Claire Therese, and 2 energetic and loving puppies, Jade, Mara Ray, and Asuka. I did say it right. She has a passion for vascular surgery, education, and providing the best care possible for her patients. And by the way, she brought props, so this will be a really great presentation. Doctor?
Thank you. Good evening. A few disclosures. I'm employed by Christiana, and I have no financial ties at all to the companies I'll mention in these talks, okay? So, vascular surgery is a relatively newer field when you look at the history of medicine in general, but really blood circulation wasn't defined until 1628, when we finally got the right idea that the arteries take blood from the heart to the body and the veins bring it back to the heart, as Dr. Harvey illustrated in his document here. So vascular surgery involves treating the diseases of the entire body with the exception of the heart and the brain. So I have the privilege of being able to operate on pretty much every part of the body in order to treat these disorders, both with open surgical techniques and the newer endovascular through the blood vessel techniques. So essentially, vascular surgeons are the plumbers of medicine with regard to the blood vessels, but to be more accurate, it would be more of this representation, since we really use everything. We use the knife and the wires and the catheters to accomplish those goals. But the arteries are not metal pipes. They're living, dynamic vessels. The arteries consist of the 3 walls, the intima, the media, and the adventitia, and they're moving and responding to blood flow. The endothelium is an amazing part of the blood vessel that vascular surgeons have great respect for. It maintains the homeostasis, or the balance of bleeding and clotting in blood vessels. And it does that through many complex pathways. It was essentially designed to clot when injured so that the body wouldn't necessarily bleed out. So injury to the endothelium results in a clotting, inflammatory kind of reaction. So it's great when it's doing its job, but we'll talk about the disorders that affect, this that have developed over time, and just result in dysfunction. I won't be going into too much detail about the veins today, but they too have 3 walls, and in addition to that, they have valves, which are assist in the return of blood flow back to the heart against gravity, essentially. So most of the valves are present in the lower extremities. And when they dysfunction, that's when you see problems like varicose veins. And when there's clots that develop there, that's another aspect of vascular surgery that we are involved in. So when we talk about plumbing, the reason why vascular surgery is like plumbing is because we're dealing with blockages and leaking. And so the blockages that we encounter are from atherosclerosis, which I'll talk about in a little more detail in a bit. Embolism, which refers to a clot that travels from somewhere else, most commonly the heart, from maybe an irregular heart rhythm, or most commonly that, but sometimes tumors in the heart can also cause a clot or something to travel and then block off an artery in another location. And so we treat that by removing that clot. And then compression of structures, sometimes by a anatomic variant, meaning maybe there is a bone or even another blood vessel, or sometimes your diaphragm, which separates your chest from your abdomen, can compress on different blood vessels and result in symptoms in patients. So we deal with that too. And then the leaking aspect of things. Now, since blood vessels are not metal pipes, they can have disorders of the connective tissue that makes up the wall. So then the wall can become weakened. It can happen from genetic connective tissue disorder. It can happen from atherosclerosis and smoking, and all that can result in weakening of the tissues in the entire body. And so that results in an aneurysm, which is a ballooning of a blood vessel to a larger diameter than what is what is normal. And those are at risk when they're in the abdomen. They're at risk for rupturing. And then when they're present in the extremities, they can rupture, but more commonly peripheral aneurysms can develop clot in them, and they can then obstruct flow. So aneurysms technically could be under either blockage or leaking. And then traumatic injury. We help trauma surgeons in dealing with injuries to blood vessels, blunt trauma, penetrating trauma from gunshots or knife wounds, and even from other surgeries. We're often called in to help other surgeons with their operations if they are close to blood vessels or if they injure blood vessels, that sort of thing. So we're really all over the hospital and all over the body. So I won't get to talk about every aspect of vascular surgery today. That it's really a lot that we treat. But I chose to focus on the advancements in atherosclerotic disease-related disorders, which is mainly PAD, or peripheral arterial disease, which is when atherosclerosis or plaque buildup happens most commonly in the legs, is what we see, where we see it. And then in carotid artery disease, which is when it affects the two of the blood vessels that go to the brain, the carotid arteries, and can result in stroke. And then AAA, or abdominal aortic aneurysms, which is when the wall of the artery becomes ballooned and is at risk for rupture. These are the big disorders that we look at in this category. A lot of patients have similar comorbidities, meaning they have similar risk factors that result in these problems. And we've made amazing advancements in the last century in how and even really the last 15 years, how we've been able to really help patients in a much more minimally invasive way. But that being said, it doesn't mean that we've let go of the past completely. We still do plenty of open surgical operations. But we'll talk about all that. So atherosclerosis is essentially an inflammatory sort of process. That's what all the, these monocytes, those are like, they're like the immune cells of the body. LDL refers, to the cholesterol. So what happens is if cholesterol present can then incite injury through inflammation along the artery wall, and then we have plaque that builds up within the artery wall, and over time it can eventually rupture and have a thrombus or a clot form in that area, sometimes completely occluding arteries. Narrowing of arteries and occlusion of arteries, they all can have very different presentations. It really depends on a lot of different factors, and we'll talk about that in a bit. But essentially, this process is a lifelong chronic disease that happens starts as early as in the first decade, with these kind of fatty streaks forming, and it just really develops over time. The risk factors, number 1, 2, and 3 is smoking. I tell my patients, because, if everybody stopped smoking, I probably would not be that busy at all, because this is the driver of so much of what I treat. There's over like 400 components or chemicals in cigarettes that kind of generate an inflammatory response, affects the connective tissues in the body, and so it's responsible for peripheral arterial disease, carotid artery disease, and aneurysm formation. And so it's always a wonderful day. I had a patient today who quit smoking. It's always wonderful when people are able to do that. It's truly an addiction, and I have nothing but respect for people who are able to take on that the burden of take that journey to quitting, because it takes multiple attempts, and when people are finally able to do it, it's really wonderful. Because honestly, anything that I do for them is jeopardized by smoking. So any treatment that I can provide for them has a lifetime, but it's drastically shortened if they continue to smoke. There are some surgeons who will not treat people who smoke. I think that's kind of ridiculous. I think you need to meet people where they are, and you need to help them make their life better. And that's part of the role of a vascular surgeon. A lot of my conversations involve, how we can come up with a plan to stop smoking. Sometimes it's just genetics, what you're born with, that results in atherosclerosis, and those kind of factors can result in high cholesterol, despite how good of a diet you might have. And sometimes it's people who don't have great diets who have this kind of outcome. High blood pressure can also be genetic, but also lifestyle related. So we're always encouraging people to be on medications and change their lifestyle to kind of improve these risk factors. And then diabetes, also highly genetic, but another contributing factor to peripheral arterial disease. This is a lot of information, but essentially similar kind of inflammatory factors are involved in the development of aneurysms, and then the breakdown of the artery wall that results in it expanding like a balloon. It's not just this, though. Patients can have familial disorders that affect the elastin that's present in the connective tissues, or other components of the connective tissues, and that result in aneurysm as well. But like I said, we're focusing on atherosclerosis at the moment, and so that's the most common presentation that we see here. Unlike PAD, in aneurysms, diabetes isn't as much of a factor there. It's kind of interesting. Some of the data seems to show that diabetes is kind of protective. Nobody can really explain well why, but as far as rupture, people who have diabetes were less likely to rupture in some studies, but so it's not as much of a factor in aneurysms, but smoking is very much so. And on that note, actually more commonly we do see this in when we see it in families, it's mostly the men in the families who are all usually smokers. And so we start screening people if they've been smoking at around 65 with ultrasound, see if they have an aneurysm. So again, to reiterate, atherosclerosis, it's a chronic disease. Unfortunately, we do not have a cure. And that's hard for some people who come to me to realize, well, I set expectations, for what they are. I can't cure a disease that's been going on, but I can help people manage their symptoms, and I can help them live a longer life without, maybe without stroke, without aneurysm rupture. I look at myself in this regard with atherosclerosis as more of a palliative surgeon, actually. Many of my patients are in their older, at the end of their lives, and we're just trying to do everything we can to come up with a plan that will last as long as they will live. But when I say vascular paths here, that's kind of that term for patients who have atherosclerosis. Most of them die of heart attacks. And that's the first thing that I emphasize with everybody about this, is that the disease that's present in the legs or in the carotids is present in the heart. And PAD is an independent risk factor for heart attacks. So that's really the main reason why people should change their lifestyle and everything, because no matter what I do, the statistics show that most people end up dying from heart attack, not from their PAD or from their carotid arteries. So I'll start with peripheral arterial disease. It manifests in really these ways. It can either be asymptomatic. They can have something called claudication, or they can have rest pain, wounds, and tissue loss. So claudication classically is when the patient will have pain in their calf or their calves when they're walking, and they walk a set distance and they get this pain. Mostly this pattern in smokers, and the disease is present in the superficial femoral artery. That's the artery that goes from the groin to the knee. That's usually the presentation. But the first treatment for claudication is always risk management, so smoking cessation, and aspirin, statin, for cholesterol, and to actually a set walking regimen. A supervised exercise program is actually best for this. I try my best to avoid treating claudication too early with surgical treatments. And that's very important because, kind of how I alluded to, because atherosclerosis is a chronic disease, we got to play the long game. You have to look at management as okay, what's going to last this patient the longest? And nothing beats your own body. So we really want to keep people walking with their own native tissues, their own native arteries as long as possible. And with supervised exercise programs and walking, to the point of pain in the calf and then a little bit further, collaterals can form. Collaterals refer to blood vessels that your body can make to get around blockages itself. So we really try not to operate too soon because there's a limited life to what we can do for this. And you don't, if you start too early, then you can progress when they may not have been on that pathway to progress. Not everybody with claudication develops tissue loss, like wounds like you see here, or rest pain. I show this picture for rest pain because typically when we say rest pain, it's because there's not enough blood flow getting to the foot. And they have pain typically across the top of the foot, and it feels a little better when they can hang it off the side of the bed and have gravity help more blood flow get there. So that's why I show that picture, because that's classic when they're suffering with this. It is a very difficult pain to treat. Narcotics can barely touch it. And if we're unable to get things open, I have patients beg me to have their legs amputated. It's really, it can get that severe. The goal is to catch these people before they're that far gone. And then we're able to do more for them. Tissue loss doesn't always happen with the rest pain, many times because a lot of these patients also have diabetes. And with diabetes, you can develop something called neuropathy and not be able to really feel your feet or where they are in space. And you can develop wounds and not realize you have them, and then those wounds can become infected. And if you don't have enough blood flow, they're not going to heal. Or they can have what's shown here is this kind of, we call it dry gangrene. It's like a mummification that happens of the toes because there's just not enough blood flow getting there. But when you progress to this point of either rest pain or tissue loss, it means that you have blockages at multiple levels in the leg. Whereas you might just have one blockage or narrowing if you had claudication only. So one way that we can measure this or screen for it, some people screen for it. There's a lot of debate about whether or not you should screen for peripheral arterial disease. It's my personal opinion that you need to recognize risk factors, but you should also recognize symptoms, because that's really what I as a vascular surgeon, am going to intervene for. The way that we can measure this, the simplest way is feeling a pulse. And you feel for the pulse at the top of your foot. That's the dorsalis pedis, or behind the inside of your ankle. That's the posterior tibial pulse. And if there's a pulse there, then there's no large vessel disease. That's normal. It's good to be able to feel pulse. Caveat with that is, not everybody's good at feeling pulses. Sometimes you can feel, even myself, there's some days where I just can't trust my own fingers, because you can sometimes feel your own pulse in your fingers. So if I'm ever questioning it, I go and I get a Doppler. Doppler is this ancient kind of device that allows you to listen to the signals. And when I listen to signals, I'm listening to the quality of the signal and like how many parts there are to it. And a normal signal will have 3 parts. It'll be like a lub-dub-dub. And that last signal kind of indicates that the vessels are compliant. So they're not hardened, so they can kind of reverberate. And so that's how you get the 3rd signal, and that's a normal healthy artery. When you can't feel pulses and you only have signals, there's peripheral arterial disease there usually. And so we have a way of measuring it by comparing the blood pressure in the arm with the blood pressure in the leg at the ankle. And normal would be close to 1 because you want them to be somewhat similar. Mild disease, when you get a ratio 0.7 to 0.9, moderate 0.5 to 0.7. When it's less than 0.4, then we say it's severe, and critical if you have rest pain and tissue loss is when really you see that critical obstruction. It's like 0, you get nothing, or 0.1 or 0.2. So it's fairly like easy way to see if somebody has arterial disease. Sorry. So this is like a schematic of the natural history, kind of alluded to it. Usually affects older people, can be asymptomatic, and may not progress. It may not be a problem at all. So I don't see any benefit to treating somebody because anything that we do has risks. So we have really great medical treatments, and we should use statins, aspirin, smoking cessation, and all that. And because asymptomatic PAD, more than anything, is a sign that you have disease in your heart. Claudication, or like I said, the pain with walking in the calves usually. Sometimes it's in the thighs. It's in the thighs if you have a blockage a little higher up in your iliac arteries. It can be in your buttock. Doesn't always progress to limb loss, but you can see it can stay stable, it can worsen, or it can go to critical limb ischemia and lead to amputation. So whenever I have a discussion with a patient about peripheral arterial disease and they have severe peripheral arterial disease, I'm just very real with them because I think it's very important to understand the disease and the expectations of the disease. I also believe you need to be compassionate when you talk to these people, of course, but I think it's important to mention that amputation could happen. Our goal is obviously to save limbs, but sometimes it's not in the cards. And we, as vascular surgeons, perform amputations of below the knee and above the knee. And most often it's in people who are smokers and diabetics. They have like the triple, kind of problem with atherosclerosis. And they come to us pretty late in the game. But I think it's important that's there because if you bring it up too late, there's a lot more of a shock factor with it, and it's much harder to help people if they're completely against amputation. Because we've also had great advancements in technology as far as prosthetics go. And it does require work, and it does require excellent physical therapy and rehab. But I've seen, when I was out in Colorado, I had this veteran who was a double above knee amputee. The amount of energy required to rehabilitate, he was able to use prosthetics. It was really amazing to me, and he had a great attitude. But I think it's important to be real, but also compassionate. It's a hard thing for people to have to deal with and realize. But again, can't overemphasize. Heart is what kills. If you have PAD, you're probably going to die of a heart attack. So when we talk about the basic ideas of how to approach a blockage like you would have really anywhere, but in this example of PAD, the components are you need inflow, you need outflow, and you need a good conduit. When we talk about conduit, we just mean what are we going to use for that bypass to jump from point A to point B. If you have a problem with one of these, then your bypass or your intervention will go down. It won't last. It's physics. So the inflow needs to be good. You need to have enough blood flow for it to get to, because you can't just go to nothing. Everything will just clot off. It has to have circulation to get to the capillaries, to get back into the veins, go back to the heart. And then conduits, we have lots of options. Vein is the best. And we get the vein from the leg, the greater saphenous vein. It's the same one that causes problems in people with varicose veins, but it's really key in coronary bypass and in bypass in the legs. And it's the vein that's from the knee to the groin. And we can use it, like flip it so that the valves are non-issue, or we can destroy the valves and use it in its original orientation. Another option would be to use a frozen vein or an artery. You could use a treated carotid from a cow. You can use graft. Now, anything but vein is nothing's as good as vein, because vein has that endothelium that I talked about earlier that provides that balance, that homeostasis, help prevent clot. It's really awesome when you can use your own vein. Graft, cryo vein, they're not as good, but they can get the job done in certain circumstances, as long as you don't have a problem with your inflow or your outflow. The graft can be Dacron, which is a type of polyester, or PTFE, which is the same thing that's in your Gore-Tex jackets or guitar strings or fishing line. PTFE was developed in the 1960s. Well, expandable PTFE, because original PTFE, we're talking about Teflon. But there was, I think it was Bob Gore in Delaware here, developed expandable PTFE, and that's how we were able to have the grafts that we use so much in the operating room, and suture. I mean, it's really an amazing product. We can look at stents in the same way. A stent's going to go down if you don't have good outflow, if you don't have good inflow. And a stent is basically it can either be a covered or it can be a metal scaffold that can expand a stenosis or narrowing in an artery. And the same goes for a segment that may have been ballooned. That's what I mean by angioplasty. It means ballooned an artery. And then finally, you can treat a blockage just by removing the plaque itself. That's called an endarterectomy. And we do this these days in locations that we can reach easily, or that have branches present that we want to preserve, because stents can get in the way of branches. So in the groin, that's where your femoral artery is. And if you have a blockage there, we treat that with endarterectomy. But a blockage in the SFA, or superficial femoral artery, that goes from the groin to the knee, that we can often do a endovascular approach. We'll talk about endovascular in a second. This is just a picture of a bypass, and it's what you would think it would be. We're taking blood from one place and taking it to another, and this is depicting a cartoon form with a vein. And so go from the femoral artery and tunnel it down to, this would probably be above knee popliteal artery. The popliteal artery is what's behind your knee. And I love this kind of surgery. I love sewing blood vessels together. It's really one of those things that's very fun to do technically. And it's great when you can have a nice result where you go from this mummy leg to being healed. Really satisfying. But it does have some morbidity associated with it. So when in 1953, Sven Seldinger, he is a radiologist, he came up with this simple, elegant concept of we can basically access a vessel using a needle and a wire and then a stiffer plastic tube called a sheath. And that revolutionized the field slowly. This is a demonstration of what that looks like. So we're able to access arteries from a peripheral site, and in the case, it can be, it's most commonly in the groins or the femoral arteries, but we can also do it from the radial artery or another artery in the arm, and then treat a site remote to that without needing to do big incisions and major surgery. So this was really simple but revolutionary concept. So the what's pictured here is an angiogram. A shows angiogram with disease of the iliac arteries. So here is the aorta. It's the biggest artery in the body, and it branches to supply the legs via the iliac arteries. And so there's a blockage here, or a narrowing here. And to do this with surgery is not a minor thing. I mean, we make an incision on the kind of flank. Sometimes we can go through the midline and need to move all the bowel out of the way and get to the back because the aorta is right in front of the spine. And then it would require sewing a conduit, usually Dacron or PTFE, from one end to the other. When you're this close to the aorta, it's actually okay to use the prosthetics. They work just as well, if not better, than a vein in this part of the body. But in the legs, the vein is better. But still, why do that if you can access through the groin and get a wire up? So in B, you see here, this is the wire going up across the lesion, and then they have a sheath and a catheter, and then eventually, you could either balloon this or just stent it and then maybe balloon it afterwards. I don't know if it projects as well, but there's these little kind of crosshatch marks that's signifying the stent that's present here in the iliac artery, going from the common iliac artery down to the external iliac artery and opening that up. And so this would be an example of treating inflow, because this is coming down to the leg. But that's a great use for endovascular technology that started with Seldinger. So here's some diagrams of what this looks like when you angioplasty or balloon an artery. You just cross the lesion, put a balloon there, and open it up. You can size it based on CAT scans that you maybe have, so you know what size balloon to put in there, and you use X-rays and dye to find out where you are. So, and this shows a stent. This is a balloon expandable stent here. And now we have atherectomy. And atherectomy is developed fairly recently, where we have these tools that can basically rotor-rooter through a plaque. But the challenge is you need to get across the plaque first in the right plane, and then you can use this device. And that's really taken off. A lot of interventionalists are doing this as a step. This is an example of an angiogram, and this is the femur, the thigh bone there, and then this is the superficial femoral artery with a narrowing here. And this individual crossed it with a wire and then stented it from here to here. I probably would have stented it just here, but that's the interesting thing about this as well is, you know, we started out stenting a lot, actually stenting the entire SFA, and then we realized that's not as great, that doesn't last as long. So now we're doing more atherectomy, which shaves down the plaque, and then ballooning it, and stenting only when necessary. Like if when you balloon it, it doesn't get bigger, then we would stent it and use just the only length that you need to. Because stent pressed against the endothelium is not as good as your native tissue. The endothelium is amazing, but if you have a stent pushed against it, if you think about it, it's like it's going to act like it's injured. And it just won't last as long. It'll last, and it'll be, you know, it'll be effective for as long, you know, for a certain amount of time. But the longer the lesion, that's when we discuss open surgery as an option for patients who are good candidates. Next is carotid artery disease. So a stroke is, I would say a stroke is can be worse than death. And 80% of strokes are caused by a problem with blood flow. And many of these are from narrowing that happens at this bifurcation in the neck. It's called the carotid body. You have 4 blood vessels that go to the brain. A vertebral artery on each side and your carotid arteries on each side. This branching point here is showing you where it goes to the brain. That's called the internal carotid artery. And then where it goes to the face, it's called the external carotid artery. So this bulb here, where it's branches, and branch points are often a point where we see atherosclerosis form. There's a low shear stress, and then plaque forms, injury forms, and eventually the plaque can rupture. An unstable plaque will result in pieces going off to the brain. If we're lucky, we can catch this when they're having what are called mini strokes, or TIAs, transient ischemic attacks. As they don't have the full deficit of a stroke, a mini stroke lasts less than 24 hours. And it can be a sign of, you know, of a stroke that could happen later. So we take that as an opportunity, the best opportunity to treat carotid disease, because then we can identify those patients and prevent stroke. When we talk about the mini stroke associated with the carotid, the first branch off of the internal carotid goes to the eye, the ophthalmic branch. If there's a little piece of plaque that goes to that, the patient will talk about having blindness on that same side as where the carotid is narrowed. It's like a shade going over the eye, or it just goes black, or sometimes it's even just like a film or a blurriness that they describe. We call that amaurosis fugax because it's this transient, fleeting blindness. That's a common presentation. Another example would be if on the opposite side of the body to where the narrowing is, they have facial droop, weakness of the extremities, that kind of thing. If we do happen to see a patient who has a full-blown stroke, as long as it's not too severe, too expansive, we can intervene to help prevent further strokes. by treating these unstable plaques, unstable carotid artery disease. The classic way to treat this is a procedure called carotid endarterectomy, or CEA as we abbreviate it. It can be done awake or asleep, and it involves an incision on the neck, as you see there, exposing the carotid artery and simply removing the plaque. The reason why I mention the awake or asleep: you have 4 blood vessels that go to the brain. Most people have an intact circle of Willis, so meaning that these blood vessels all connect in the brain, and if one is completely blocked off, the others can take over. If we do this procedure awake, that's the most sensitive way of telling if you're one of those people. If you're one of the people who does not have that intact kind of circulation or enough flow from the other side, what happens is, as we're doing neuro exams during the operation, it's cool for sometimes. So as long as the patient isn't too anxious, it's good. But what can happen is they just go, it's like an off switch when we clamp the internal carotid artery. It's not even that they'd have stroke symptoms, it's just like you turned them off. And then when you open it up, they're back, they're completely back, like nothing happened. If they're one of those people that turns off, we then can use a shunt during the procedure. So the shunt isn't without risks. It's safe, but if you can get away without using it, the surgery goes by faster. But the shunt is basically this tube that we place into the internal carotid artery and then into the common carotid artery here. So then while we're working, we just work around this tube. They have blood flow going to their brain. But it's not the end of the world if we have to do this asleep. People, different surgeons have different ways of deciding whether to use a shunt or not. I just use a shunt on everyone if I have them asleep because I think that's the safest thing to do. But there are people who will check something called stump pressures, or the pressure of the back bleeding from the internal carotid artery. There are people who will do like EEG monitoring or measure the kind of oxygenation of the brain through these non-invasive measures. None of them have been proven as good as just having the patient awake, so that's why I just shunt people if I have them asleep. It's not a big deal. And then we sew, after we get this plaque out, we sew a patch on. This is an example of a Dacron patch, but you can also use treated bovine pericardium, or the lining that outside of the heart from a cow that's been treated. It's very similar in kind of texture to blood vessels, so I prefer that in my operations. And this is kind of the intraoperative pictures, kind of maybe difficult to see, but this is the shunt, this plastic thing inside the artery. This yellow thing is the plaque being removed. These are the instruments that we use, and they have these rubber, like, what are they called? Tubes to maintain clamping. So this is a picture of what the plaque looks like. I have so many of these on my phone. And I think they're just so cool when you can get it all out in one and you can see just how extensive it was. And even here, this is a good example of an ulcerated plaque. But with these procedures, the scariest part is afterward. You want to make sure that they didn't have a stroke during the procedure. The risk of stroke with carotid endarterectomy is pretty low. If you're asymptomatic without symptoms, and this is just being done prophylactically because you have a really narrow artery, it's less than 1%. But it's a little higher, 1 to 5%, if you've had a prior stroke because you have a more dangerous kind of plaque. And so that's the scariest part. So we make sure that they wake up and that they're okay. You can have bleeding or hematoma at the site after this. There are nerves, they're called cranial nerves in the neck that go to the face and the tongue and to your voice box. And we're very careful to avoid even touching those because sometimes even moving them out of the way can make them act up in certain people. And yet when that happens, it gets better like 90% of the time. So those are the different concerns with it, but it's been found to be a great operation in preventing stroke. So when we had the endovascular revolution that began with Seldinger and continued with Dotter, who did the first angioplasty, and with the first stents by Palmaz, we then, the last frontier in this kind of era and was the carotid. So transfemoral stenting, meaning going through the groin and all the way up the abdomen through the aorta to the aortic arch, which is pictured here. That's what right before comes out of the heart. Going all the way up there and then crossing the arch and then going up into the common carotid, into the internal carotid to place a stent. But most of the data comparing stenting with carotid endarterectomy seem to show what you would probably think of intuitively, that there would be a higher risk of stroke when you're passing a wire through a lesion that's been breaking off pieces of plaque. So different devices were developed to help protect the brain, and this embolic protection device that is most commonly used is this filter here. Looks like a little umbrella. And after you cross the lesion, you can place this umbrella there and it can catch the atheromas or thrombi that might go up there as you're working. But there's other protection mechanisms. One of them is called flow reversal, which I really like because you don't need to necessarily cross the lesion to protect the brain. But it only will work if you're one of the most people whose 3 other blood vessels that go to the brain will compensate if you don't have use of the one, because there's no way to really shunt when you're stenting. So most recently, let me see, where am I going? This transcarotid artery revascularization was developed, and this is a really cool concept. It allows you to access the carotid, the common carotid in the neck, through a little incision, avoiding any sort of injury to the cranial nerves that are higher up. And it can work, actually, it still works pretty well, and people have maybe had radiation or scarring or prior surgery in the neck, because usually down here is spared. And it uses that in combination with flow reversal to protect the brain. So this is a diagram of it, and I'm going to show a movie that will hopefully work, where you have this flow reversal system where it's connecting through the sheath access at the base of the neck here in the common carotid to the femoral vein on the other side, and it will bring the direction of flow into that vein so the blood flow is not going up to the brain. And then you can work, and then it has a little filter in here that will catch anything that breaks off as you're working with the wire crossing the lesion and putting a stent there. And it's just as a video that shows what I just told you. I think it's a really neat thing because if you don't have to cross the arch, anytime you cross something, it can flick something off and go to the brain. So any sort of vessel that comes off where you have a blood vessel, where you have a wire, it can potentially cause a stroke when you're working in the aortic arch. So it's neat to be able to bypass that with this and reduce the stroke rate. So they've used Seldinger's technique and got access to the common carotid artery. They've set up this flow reversal system to the vein on the other side, which is low pressure. So we'll go from high to low pressure. And that has a little filter in there. And there's the stent being deployed in the vessel. And then all those little pieces are going back into the device. So it's a promising technology. The data for it so far is pretty good, but what we really need to see is a contemporary direct comparison between this and the carotid endarterectomy, which is still the gold standard. So I'll offer this procedure to people who are high risk for carotid endarterectomy, for open surgery, and then if they had radiation or if they had surgery in the neck prior, that kind of thing. But otherwise, I will typically recommend carotid endarterectomy, just since the data still, needs to be hashed out. So we can have our break now, and we'll come back and talk about Einstein. All right, so we're back. This last part will not be as long as the first. I hope that's okay with you. We'll end a little early. But I'm going to talk about a little story and get more into the history, just because I think this last part allows that to be explained well. So Einstein presented his first theory of relativity when he was 26. And then years after that, he immigrated to the United States, flee Nazi Germany. He was in New Jersey in 1948 when he had abdominal pain. And he had been seeing a doctor for a while about abdominal pain, and they seemed to think it was from his gallbladder. And the gallbladder is under the liver on the right side of the body, and if you have fatty meal, it can get acted up. But he was having abdominal pain and then passed out in his bathroom, and so he saw a surgeon called Dr. Nissen, who's very famous from a different operation, but he also immigrated to the U.S. around the same time. And he felt his abdomen, and it felt pulsatile, felt like there was a bulge there. And he diagnosed Einstein with a abdominal aortic aneurysm. So this was in 1948, again, which is before we had our vascular ultrasound, before we had CAT scan. So he did an exploratory laparotomy, which is where we open the abdomen from your breastbone, your sternum, down to your pubic bone, and then look at the old insides. And he found that the gallbladder was normal, and indeed there was a aneurysm there. And it looked like it was about, or had begun to be in the process of rupturing. And it was the size of this grapefruit. It was almost 10 centimeters. And this was in, again, 1948, and this was before we had any real treatment for aneurysms besides tying them off. And so this aneurysm was present underneath the renal arteries, which go to the kidneys. And so tying it off would mean no blood flow to the legs. And so he didn't want to offer that kind of archaic concept to Einstein. So what he did was he wrapped it in cellophane, because that was his best guess as to what to do in 1948. And the idea was that it would incite an inflammatory fibrotic reaction around the aneurysm. But it's amazing. Einstein went on to live another 7 years when a patient with a 10 centimeter aneurysm will likely rupture that year. So it did something. It treated him at least for 7 years. And then when he was, I guess he was in his 70s at that time, in 1955, he had abdominal pain again, and he had a ruptured aneurysm. And by this time, 1955, in 1954, the first aortic aneurysm repair with Dacron graft replacing the aorta was done. And so there was a surgeon who was familiar with this operation who came and saw Einstein, and he said that no thanks, that he would rather die elegantly, is how he put it. And so he turned down the surgery, and he died of a ruptured abdominal aortic aneurysm. But I think that it's just absolutely amazing how far we've come with how we're able to treat this disease process. So the open surgical repair that was done first in 1954 replaces the diseased segment of the aorta with this graft, this Dacron graft. It can either be a straight tube if you're just going down to here, or it could be bifurcated, as you see here, and you sew it in place. You have to clamp the aorta, and then it's pretty straightforward if you're not involving these arteries that come off the aorta higher up. And you sew up the sac, and then you sew up the patient, and you're done. And they're in the hospital for a while recovering from that. And when you have a patient who's in there, especially in their 70s and beyond, it's a big hit. It's a big deal to have this major operation, and they can develop pneumonia and other infections on top of this, just by virtue of having a weakened system, being older. But and this is just showing like how we have to move the bowel out of the way, like I alluded to earlier, to get to where the aorta is. It lies in the back of the body, in front of the spine. But as much as I love doing this operation, and any really open surgical operation, I love my patients more. Like we can do better, and we have this amazing new way of doing it. These are more intraoperative pictures of sewing this in place. So this is this timeline, which I thought was really cool to put things in perspective. So ultrasound is based on the concept that sound waves depend on the speed source. That was developed by Doppler in 1842. That old concept, but we would find that it wasn't until much later that we're actually using it in medical practice. X-rays were discovered in 1895. In the 1920s, that's when we had the first successful treatment of aortic aneurysm by just tying it off. And luckily, this person had enough collateral blood flow not to die from no blood flow to their legs. The first angiogram, or where we shoot a picture of the blood vessels, that was done in the 1920s. The first heart cath was done in the 1920s. We had a little bit of a variation on how to treat an aneurysm with ligating it, not only ligating it, but kind of plicating it as well in 1940. And we had the cellophane repair in 1948. And then the first successful open AAA in 1951, that was done with a cadaveric aorta from a deceased individual and had been treated and was placed in the patient. That's not how we do it today. We use the Dacron, which was done in 1954. Seldinger, who I talked about earlier, revolutionizing how we do things in medicine, really. It was in 1953. Then we have, when Einstein died, it was the same year that we started using ultrasound to look at blood vessels. In the 1960s, that's when we first did the first percutaneous angioplasty. That means, like in this case, he was actually using a bigger sheath rather than a balloon to go through and open up a narrow area. And we're using Doppler in the 1960s. But 1979 is when Hounsfield won the Nobel Prize for CT technology. And man, I love CAT scans. I think that they're just amazing, and I use them in every possible opportunity I can in planning operations when it's reasonable. They're not widely available, though, till the 1980s, and we have the first balloon expandable stent in 1985. All of these advancements finally led up to the first endovascular repair of an aneurysm by Perotti in 1990. And it's just really revolutionized the field. And of course, we see a little delay because, the first one's done by a pioneer. It wasn't until 1999 that EVARs were FDA approved to treat it. And then in the early 2000s, we have the development of the beginnings of grafts that we use today. It's resulted in this 3.5-fold decrease in operative mortality, and it's truly changed how we can treat people. So an endograft repair combines the concepts that we talked about. You access peripheral artery, very small incision, less than 5 millimeters in each groin, and you position this graft so that the blood will flow through this graft, which is made of a metal scaffold and covered in fabric, and then it will seal in the normal aorta, and then the blood flow will just go through it and not go into this diseased, we call it the aortic sac, and so that won't continue to expand unless you have either not a good enough seal or you have blood flow coming from another vessel that you can't address initially. This is another picture of how, where the aneurysm is located most commonly, and what is most easily treated with an endograft is when it's below the renal arteries, like you see here. And that's what it looks a lot like this in the operating room when you do it open. You've got this atheromatous junk and everything, but I mean, I'll tell you, when I was an intern here, I saw a lot of ruptured aneurysms, and the way it happened was they call code overhead. We call them all trauma codes because you need to activate everybody. Everybody's got to get there. When you have the biggest artery in your body bursting, you need to act quickly. And as a surgical resident, we all go to the trauma codes, and that year, I'm pretty sure, I don't think I had anyone survive who I was part of their care, because at that time, even though endograft was available for rupture, we just didn't have there just wasn't a good system in place. You need good teams to get things done, and everybody's got to be on the same page. So in the first year of my 5-year residency, we were cracking open chests and cross-clamping the aorta in the chest to keep people alive, and maybe that would get them up, to the OR where they could get a replacement, but then they would die in the ICU. Or often these patients could even die in the operating room because of the massive blood loss that's happening. And the predictive factor at that time and earlier of whether you were going to live or not if you had an aortic aneurysm, and I'll tell you, 50% of people don't even make it to the hospital. So if you make it to the hospital, the predictive factor is how quickly can you get control and stop the bleeding by putting a clamp above where the aneurysm is ruptured. Ideally up here, but if you're desperate, you might need to go up here because maybe it's quicker. So that was the predictive factor back when I was an intern. Over my 5-year residency, by the time I was a chief resident, we were doing ruptured aortic aneurysms under local anesthesia, and the patient is able to go home post-op day 1 sometimes day 2. Because we had a system with the emergency department, with our teams in the operating room who knew how to use all of our tools, which are very different from our usual open surgery tools. And it's just amazing how that has truly revolutionized it. Now when we have a ruptured AAA, we still act quick, but people have such a better chance of surviving. It's changed our algorithm for how to treat people when they come in as a code. We will do everything we can to get them to the CAT scan, even if they have a low blood pressure, because that CAT scan will help us determine if we can do this safely with an endograft. Is it an aneurysm that ruptured down here? Because if it's an aneurysm that ruptured up here, we're still doing those open. We don't have a fast enough way to do it endovascularly. We'll talk a little bit more about how the options we do have to treat that. But so in my mind, the most important thing is not only for the ER to get good access so we could have blood, but we actually want to keep their blood pressure low so that they don't bleed out. And we get them to survive that CAT scan. We don't intubate them, because intubating them, as long as they're protecting their airway, most of them are at this point, intubating them, those medications could make them crash and code, their blood pressure drop too low. So that's why we say, get your access, go to the scanner, get our pictures, and then we know if we can do it endovascularly or open, and then we're able to get this done very quickly. This procedure can take less than an hour if it's planned properly. It just never ceases to amaze me what we've been able to do. If you are a patient who we would consider a vasculopath, I suppose, like Einstein, but that has risk factors like smoking, maybe even a family history of aortic aneurysms, we now can screen people for their aneurysms, and we found that if we find an aneurysm and it's 5.5 centimeters or greater, we can prophylactically treat them to prevent the aneurysm from expanding further. That's like this size compared to, so we're treating them when they're this size so they don't get any bigger. And we do that with ultrasound, and that allows us to use the sound waves to then see the structures in a non-invasive way. And then once it gets to be above 5 centimeters is when I will transition them to CAT scan and see if they're a candidate. We can plan a procedure for them to help prevent it. This is a picture of the caveat with doing things through the blood vessel. If you're doing it through the blood vessel, then you still could have other vessels that could back bleed into the sac, because then this becomes a low pressure situation. And so then you can have retrograde flow. We call that a type 2 endoleak. It's not a big deal. It's something that we watch. Most of the time they clot off on their own is what we found. We then have to monitor the patients every year. After we first put it in, it's shorter intervals, but then we are able to bring it out to every year. And we're looking for other endoleak possibilities, which could be from, a seal. Because what can happen is over time, the aorta can change shape as you age, and it can things can move around, or a graft could slip as a result of that. And so you could end up with a type 1 endoleak, which is bleeding from either this end or this end down here. Sometimes these segments can become aneurysmal because people who have aneurysms tend to get them in other places. And then they may need an extension later. So even though we've dramatically improved mortality up front and morbidity, and we've prevented rupture, we do still need to watch the patients, and there is an increased incidence of needing to intervene later, whereas with the open surgery, you don't need to monitor that with CAT scans or anything that lasts. But these are other examples of endoleaks. This type 3 endoleak is when there's a junctional kind of like disruption. So maybe over time it kind of separates, and so they can bleed in between if there's not enough seal in between components. This doesn't happen anymore because our materials are much better than they were with the initial round of endografts that were developed. I'm trying to go back here. So just as I showed the angiogram images, the other things, this is an angiogram of an aortic aneurysm and subsequent treatment with the endograft. That's a beautiful result. And the idea is obviously to preserve the important visceral vessels, the renal arteries, and the superior mesenteric artery, which is a little higher, and the celiac artery. So when we have aneurysms that involve that part, the challenge is preserving flow. So if you have a good operative candidate, I will offer them open surgery usually if they can tolerate it. But it's a big deal because it would mean clamping the artery above these blood vessels, so those, your kidneys and your bowel would temporarily not have blood flow. We don't use bypass for the procedures that involve the superior mesenteric artery and the renal arteries. We don't use like open heart bypass for that. Sometimes the aneurysms can involve higher up, and that's when we would use left heart bypass in conjunction with our cardiac surgery colleagues and do an open procedure replacing all that. In the University of Colorado, we were working on newer technology, and other places in the country are really after this next frontier of endovascular treatment of aneurysms. Now, logically, it'd be let's go for the next branch. And there's eventually a commercially developed device by Cook called the ZFEN device. You can have a CAT scan, and you can put all the measurements in an order form, and you give it to the Cook company, and they'll send it to New Zealand or Australia, one of those, I forget, and they'll make it there and then send it back. But it takes like 2 weeks, and there's a lot of constraints because it is a manufactured kind of process. So it doesn't work for everybody, but for who it works, you can treat aneurysms that involve the renals, and sometimes a little more than the renals with these devices, and then they have little holes that you need to line up perfectly and then put stents across into those vessels to preserve them. So we can sometimes treat aneurysms that way if you have, the time to wait for it to come back in the mail and if it's anatomically going to work. But in Colorado, what we did was we specially made these devices for people. It's a very involved process where we would use the CAT scan, and this is a 3D reconstruction of the CAT scan, and this demonstrates all of the arc angles that were measured and the distances so that it could be translated to where to put it on a graft. And then we used CAD software to illustrate this, so when we went to the operating room to do this, as you see here, we're making these holes. We're sewing a little coil around it so that you can see it on x-ray, see the holes on x-ray, reinforcing it with a little ring and suturing it, and it's custom made and perfectly made for the patient. The thing is, you need to have an FDA exemption to be able to modify a device, and luckily Dr. Kuyama at the University, now he's at Dartmouth, but he was at the University of Colorado when I was there, was one of the few people in the country who was able to do this. It was very cool. Very cool to be able to treat, they're called thoracoabdominal aortic aneurysms because they involve more, they can involve the chest and below in this way. And people were able to go home, a couple days later often. It was a really satisfying experience. And this is some pictures of what it looked like in the operating room. We now have technology where we can onlay CAT scans and create 3D lines to guide where we go. I think it's so cool. And this is a beautiful picture of it perfectly lining up and with the stent in place with just a little bit inside and ballooned out. So that's an example of a PMEG. We call it PMEG. It's physician-modified endograft. But there's a lot of innovation happening in this field where now the device companies are coming up with more off-the-shelf devices like that's an example of a PMEG that we did where we basically stent grafted the entire aorta down. It was pretty impressive. This was not for, it was for aneurysm, but a kind of different cause of it, but that was really fun. But this is the Tambra device by Gore, where they are using both arm access and groin access to deploy this graft that has branches that can then go into the visceral vessels and treat these aneurysms that don't have enough of a landing zone, maybe. And there's some of my colleagues out in Washington State. They're using, I think it's super awesome, the 3D printing and trying to find applications for that in designing these grafts. And so there's a lot of innovation happening in the field that's exciting. I'm sure that there's always going to be a recoil, and we'll figure out what's wrong with doing it this way and then maybe go back to old ways and rehash it and go through. But it's really been an exciting time in vascular surgery, and especially with aortic aneurysms, I think. But I'll end it here for any questions. I think I have one here. To start it off, somebody slipped it up here. If a person has plaque, can exercise and eating better help decrease plaque in the arteries? As far as I know right now, the only thing that we've seen that's been able to reverse atherosclerosis are statin medications. There's a lot of promising literature to support the use of statins, and I don't think that exercise and eating better alone can accomplish that. It can stop it from progressing, potentially. It can definitely help things in that way. But really, the statins are an amazing drug, and I want all my patients, all my vascular path patients, on aspirin and statin at baseline, really. Were there any other questions over there?
Speak a little bit about aneurysm.
So the question was, can you speak a little bit about aortic saccular aneurysm? So I think that what you're referring to is the fusiform morphology, which can also be described as saccular. I think that's what you mean. That is morphology more common with atherosclerotic associated aneurysms. There are some studies that suggest they may be more likely to rupture than other morphologies, but right now the most robust data correlates rupture with size and the diameter. But does that answer your question?
Yes.
Okay. Oh, aortic aneurysms or cerebral aneurysm? Okay. Because saccular aneurysms is a terminology also used for aneurysms in the brain, and sometimes they can go together. And when there's genetic diseases of the connective tissues, it'll affect the arteries all over the body. It is not unreasonable to suspect if you have an aneurysm in one place to check in others. So aortic aneurysms often will have popliteal aneurysms associated with them and vice versa, and iliac artery aneurysms in the abdomen. The different genetic predispositions depend on what you might be looking for. There are connective tissue disorders like Marfan syndrome and Louis-Dietz, and even something called Ehlers-Danlos that can be associated with dissection and aneurysm. Some vasculitis associated aneurysms make us concerned, and we look for like maybe aneurysms that go in the renal arteries or in the brain. So there's a lot that can go along with that terminology of saccular aneurysm and genetically associated aneurysm.
You had stated that if an aneurysm is at a certain diameter or size, that you can do proactively.
Yeah.
If you're aware that you have an aneurysm, what is the standard for monitoring that? How do you know, like if you scan, you have one?
Right. The question was, what is the standard protocol for if you're diagnosed with an aneurysm, and how do you follow it? Did I get that right, basically? If you have an aneurysm, you should see a vascular surgeon. I don't mind seeing people with aneurysms as small as 3 centimeters or as big as 10 centimeters. If it's between 3 and 4 centimeters, we will surveil it with ultrasound every 2 to 3 years, as long as after it's discovered there hasn't been a change, an acute change. When it's between 4 and 5 centimeters, still with ultrasound, I'll just want to look at it every year. And then once we get closer to when we would recommend treating it, we would change over to CAT scan at 5 centimeters, monitor the growth. Because the rate of growth is another factor that we look at. They can, if they grow greater than 0.5 centimeter in a year, we pay a little more attention to it and consider repair depending upon its size. That makes me think about infectious related aneurysms. So that blood vessels can actually become infected, and it's called an aortitis. And when they do, they can become aneurysmal. And so that's another aspect of vascular surgery that's pretty interesting. Those aneurysms are usually associated, they like come on like very suddenly, and you have fever, fatigue, and usually elevated inflammatory markers, and then they rapidly increase in size, and we're more likely to fix those sooner since they're more likely to rupture. Those should be fixed open and try to avoid the use of prosthetic. There's a few ways to do that, or we can, if we're dealing with an infected field, it has been shown to be safe to use Dacron. I don't think I have Dacron here, but it's like a polyester. You can soak it in an antibiotic called rifampin and then use that to replace an infected aorta. But you just made me think of that because that would be an instance where it would really rapidly increase in size. But the natural progression of these is to increase. So we do watch them, fairly closely, depending upon the size.
If you have some type of plaque, say in your brain, or even if it was in an artery here, how do you get to, like, if you talked about going past the lesion and stuff, what happens if you accidentally like push it or something? What if you're in the brain? Like, what happens?
Yeah, I'm not in the brain. Our neurointerventional colleagues work on the brain, and I stop at the base of the skull with what I do, but that's absolutely a concern, and we are very careful. We're very careful with any sort of interventions where we're crossing blood vessels that go to the brain because the stroke risk is high. So we're cleaning our wires of clot. We make sure no air bubbles go up where we're working, and you are very careful with the wire, very careful. If that were to happen, it could damage the artery. It can cause a stroke. I mean, it is a big deal. And so often, even when at this institution and in Colorado, we would do our carotid stenting with the neurointerventionalists who work on the brain all the time. They're the doctors who, when you have a stroke, they get the clot out of the brain if you're a candidate. They're the ones who go all the way up into the brain. They can suck out the clot, and that's the neurointerventional radiologists. Sometimes they're neurosurgeons, but I'm very much a fan of teamwork. And so in those cases, we do work with them as well, and everybody's on the ball and checking each other and being careful. Right. So we have, Christiana is awesome. I can't say this enough. That's why I came back from beautiful Colorado, although they're getting a snow blizzard right now. But we do so many carotids that we have a great system. 4E here in upstairs is where our vascular nurses are, and they're on point. Everybody has to be, prepared for the complications that can happen, and so we're able to do the procedure. If everything goes smoothly, get them up into 4E. They're on the ball, watching blood pressure, watching for signs of stroke and bleeding, and if they're fine by morning, we can send them home the next day. Yeah.
You talked about smoking as a contributing factor to heart disease, aneurysm, etc. Would that include smoking marijuana?
Oh, gosh. Okay. So the question was, I talked about how smoking can cause heart disease, aneurysm, atherosclerosis. What about marijuana? Also, coming from Colorado, I got this question all the time. We do not have any evidence because this has not been studied. So that's the blanket statement. But personally, I think that that cigarettes are much more dangerous. Absolutely, we need to open up clinical trials to learn more about marijuana and standardize its, production, safety, and all that kind of things, because there's a lot of elements that are not controlled. And I'm speaking of this thinking as a scientist. So the doctor answer is, I don't know, but I can't say no that you shouldn't do it. I don't personally believe that there's an association with it. We just need to learn more. There you go.
May I ask 2 questions?
Yes.
Okay. First question is, as a follow-up to her previous question, by smoking as being a contributing factor to cardiovascular disease, do you include secondhand smoking? Because I don't know if.
Unfortunately, yes. Passive smoking, secondhand smoking has been shown to have similar effects. Not as severe, but absolutely.
My second question is, let's say in a traumatic accident or something, somebody has an injury to their leg or their arm, and you have to apply a tourniquet or maybe 2 if it's really severe. How do tourniquets over time damage arteries and veins? Because I know if you apply them too tightly or something, I learned they said you can internally damage the muscles, nerves, and arteries. But I don't know how. So all I know is that it applies pressure to stop the blood flow.
Absolutely. That's an excellent question. So his second question was how basically in the setting of a trauma, tourniquets can be applied or external compression with a device that can tighten around a vessel to help stop bleeding in the field, and what are the effects on the blood vessels with that. So tourniquets save lives, and I think it's awesome. Our first responders, and when they're well trained and they apply it appropriately, it's awesome. They get us here, and we're able to then assess things and go from there. There have definitely been times where we have patients who come from an outside hospital and there was bad communication, didn't know, somehow it was missed that a tourniquet was still on, and they're doing imaging and there's no blood flow, and it's it's because the tourniquet's on. A tourniquet that's on for too long can result in thrombosis of the arteries distal to that. As far as if it can directly damage the artery, I think that it can, but it's less likely in a young, healthy patient to do that because you have a lot of soft tissue kind of cushioning around where your arteries are located. If you have a frail, maybe elderly person with calcified arteries and you apply pressure too hard, you can break plaque, and that can damage the inside of the artery and then cause it to clot or dissect, which means that the artery wall gets separated and blood goes through an area where it shouldn't go. But either way, whatever the problem is, we can address it, fix it, so as long as it's recognized. The cool thing about being a vascular surgeon is you can problem solve pretty much anything and come up with a solution, as long as the ischemic time's not too long. So when you get over 6 hours of ischemic time to your muscle, it'll start to die. And so when we then return blood flow to an area that hasn't had blood flow in a while, then you need to release the muscles so that they don't swell too much. And if we see them when they're maybe they've had ischemic time for much longer than that and they can't move their legs, they're basically paralyzed. That nerve death can mean that the leg isn't salvageable at all. Usually we still try. Sometimes we get lucky, but sometimes patients need amputation. Yes?
You mentioned that a symptom of a mini stroke would be blindness in one eye or like a shade coming down. However, patients with eye issues such as like a retinal detachment exhibit the same symptoms. So how would you decipher that?
Excellent question. So the question was, how do you discern the difference between amaurosis fugax, which is where you have temporary blindness in one eye, it's the same side as carotid disease, and a retinal detachment, or another ophthalmologic disorder. I think the key factor is that it's transient and intermittent, but if I have any question, I absolutely have them see a retinal specialist, an ophthalmologist, and a neurologist. I love teamwork, and so we all can talk, ideally, directly, and then decide what's best. It's usually when there's really severe disease, carotid disease, that's when we'll lean to doing something about it, even if we're on the fence. It does depend case on case, and I really believe in really just making sure everybody puts their opinion in and decides. Yes?
What is the incidence difference between children versus adults?
And the question was, what is the incidence difference between children and adults with aneurysms? It is very rare for children to get abdominal aortic aneurysms. Children can get aneurysms. Usually it's associated with a connective tissue disease that is genetic. They are rare but present. The treatment for that would be open surgery usually. But sometimes if it's associated with an inflammatory disorder, which can be in young patients, you need to treat them with steroids first, let them overcome that inflammatory period, and then you treat them later. But it happens, but very, very rare. Yes? Okay, great question. The question was, when you take the plaque out, is it important that you take it out in one piece? And if so, why? Is that right? Okay. So I'll use the example of carotid endarterectomy, my favorite operation. The plaque will usually come out all together. It's nice when it does that because then you don't have to deal with little pieces, but it's not absolutely necessary. The most important part of that for me, that part of the operation for me, is making sure that the end point, which is the side that goes to the brain, the distal side of the internal carotid artery, that end point will not flick up, will not move at all, or allow for, when blood does come back, to get in between the plaque and the rest of the artery wall. That's called a dissection, when blood goes in between the wall of the artery. And so I'm very OCD about that, and I need to make sure I see everything clearly and that it's a nice, the ideal thing is if it feathers, just how the plaque will kind of usually easily transition to a point and then feather down. If it doesn't, then I tack it down with some little sutures to keep it from doing that. But that was a great question. All right, well, feel free to come up here to look at some of the devices.